So the point is partly as an exercise of can you give a 5-minute talk. So we have 5 examples of 5 6-minute talks, mostly as advertisements, like I said, for the posters that are over there. So once we get through 5 of those talks, we'll all convene over to the posters and swing by the beverage table on the way. So if that sounds good, I'll have Katie come up and start.
Hi everyone, and thanks for the opportunity to talk today really briefly. I'm just going to talk briefly about a project that I've been working on with Jason. So I came to CDHA last year as a postdoc. And this project is looking at intergenerational health mobility. And we're going to be using AdHealth to look at this. So just kind of really brief background here. There's 2 papers that are kind of very influential for framing this paper. The first is a working paper by Bosch Mazumder, Tim Halliday, and Ashley Wong, looking at intergenerational health mobility in the United States, and they're using the PSID. So basically the idea here is looking at the relationship between a parent's health and a child's health. And what they're finding is that intergenerational health mobility in the United States tends to be pretty high. But then we're also going to be looking at this within a context of the different variation that might be in the United States. So I'm sure a lot of folks have seen this map from the Chetty research, right, where there's a lot of spatial heterogeneity in terms of intergenerational economic mobility. And so what this paper is going to do is it's going to be looking at different types of variation, specifically spatial variation in intergenerational health mobility. So basically this is what we're going to try to do. We want to estimate the intergenerational health mobility statistic in the United States. We're going to be looking at whether non-genetic factors might be playing a role. We're going to be also then considering the different types of heterogeneity that might be present. We're going to be looking at race, ethnicity, parent-child characteristics, and then of course geography. So we're using AdHealth. There's 4 key mobility metrics that we're going to be focusing on. Right, we're going to be focusing on relative mobility. So this is kind of similar to a correlation type measure between parent and child health. And then we're also going to be looking at the expected rank conditional on knowing what your parent's health status was. So within these contexts, there's going to be kind of a level type measure, which in the intergenerational income mobility literature would be similar to a log-log specification. But we're also going to be doing this in terms of rank, which we can talk about more later, but the rank type measures seem to have better properties adhering to the assumption of linearity in this estimation. So we're going to be using self-rated health status, which of course in most surveys is just a 5-point Likert scale. We're going to rescale that so that, you know, poor health is about 15, I think. Fair health is 50, just so that the marginal distribution might represent a little bit more the marginal differences between poor, fair, good, very good, and excellent health. So this is a basic specification that's used in a lot of the intergenerational mobility research, and we're just going to be applying it to health. So you can see kind of where the relative mobility statistic is basically just the slope coefficient of the OLS specification. And absolute mobility is going to be using both the intercept and the slope, conditional on knowing the parent's health rank. So here is what we are finding. There is a lot of variation by demographics and parent-child characteristics. So the things to highlight here are that in terms of the rank slope, it seems that Hispanics tend to have relatively higher relative mobility, right? So a lower rank slope here means that there's less correlation between the 2 generations. Across the demographics here, we're seeing fairly consistent absolute mobility when a parent's health is around the 25th percentile. But when the parent's health is around the 75th percentile, it appears that there might be some more downward mobility among Hispanic parent-child pairs. And you can see in the table that typical characteristics that we might think of as advantageous or disadvantageous seem to persist within this context as well. So things like having a mother who has lower educational attainment, parents who are not married, or not having health insurance may be disadvantageous as well in terms of the intergenerational health mobility context. We also are going to be looking at spatial variation. So here we're looking at the spatial variation of schools in Ad Health. And what you can see is that there's a lot of variation across different schools, right? So in this picture here on your left, the red line is our mean in the Ad Health sample. And so then the black dots and the corresponding confidence intervals are looking at what we are estimating within each school. So there's a lot of variation about this mean. And then we take those estimates, we take a look at some of the place correlates of these estimates. And we're finding just a couple of things to highlight here. The percentage of single parents in the area tends to decrease the relative mobility measure. Having a school PTA might be indicative of having slightly higher relative mobility, so that you can see with a lower relative slope coefficient here. Having a health education requirement might be boosting your expected rank as a child if there's a health education requirement in your district. One of the comments from one of the reviewers that we've had so far indicates that, how can we actually distinguish what we see on the left here from just variation and noise? So I'm going to be interested to hear what you think. Our hypothesis here is that if the variation is non-random, then we should have more deviation, more variation from our sample mean. So basically what we're doing here is we're just calculating the integral for underneath the curve, different absolute value of the sum of all of our different schools away from the mean. And we're doing this for 100 replications, where we are randomly assigning parent-child pairs to different schools, keeping the size of the schools consistent as we do these replications. And what we're finding is that our hypothesis seems to be holding, that in terms of the rank health, or the rank slope coefficient, and both of the absolute mobility metrics, we do find that the Ad Health sample has significantly more variation from the mean than what random replications tend to have. The statistic that it doesn't hold for is the level-based metric. So this is when we're just using level parent health and level parent child without putting it into ranks, which we can talk about more later. We're thinking that has to do with the nonlinearities of that metric, and that there could be more variation than within there that we're kind of capturing. So with that, look forward to comments and questions in the poster session. So thanks.
Great. Hi, my name is Nathan Seltzer. I'm a PhD candidate in the sociology department and a trainee at CDHA. Today I'm going to be presenting research on the economic underpinnings of the drug epidemic. So the United States is currently in the throes of a fatal drug epidemic that's taken the lives of about 700,000 people over the past 2 decades. In 1999, about 17,000 people died per year from drug overdoses. Today, most recently in 2017, the number that's dying is about 70,000 per year. We often hear about the opioid crisis, and this comprises 60% of the broader drug epidemic. But researchers and policymakers often overlook the magnitude of deaths from other drugs, which make up the other 40%, which saw an increase from about 11,000 per year to 22,000 per year over this time period. In recent years, we've learned a lot about drug manufacturers and pharmaceutical companies and their practically diabolical business plans to flood local communities with endless supplies of opioids. And these pharmaceutical companies certainly played a critical role in getting people addicted to prescription painkillers and opioids more generally. But once we place the prescription opioid deaths into the context of the broader drug epidemic, we have to grapple with the possibility that the roots of this epidemic are not solely the result of easy access to prescription painkillers. Instead, we need to also consider the importance of demand-side characteristics, factors that either promote or dampen substance use at the population level. One motivation for this argument is that drug deaths aren't distributed randomly across the country, but are clustered in places that have experienced long-standing economic decline. And in this case, supply may be endogenous with demand. So pharmaceutical companies such as Purdue Pharma, for instance, they didn't simply place their finger on a random community and then decide to send their drug representatives there. Enough previous research has documented how many of the hardest hit regions of the ongoing opioid crisis have also endured decades of deteriorating economic conditions. And journalistic accounts also suggest that pharmaceutical companies targeted distressed communities. But as I've noted, the drug epidemic is larger than just opioids. And this all motivates the necessity to test for whether spatial variation in drug mortality might be explained by upstream social and economic characteristics. So in this study, what I do is I examine whether economic variation across states might help explain differences in the rise of drug mortality. Now, I focus on the decline of manufacturing jobs specifically because manufacturing represents perhaps the starkest measure of structural economic change over the past several decades. Since 1999, the US has lost approximately 4.5 million manufacturing jobs, and these lost jobs represent well-paying middle-skill positions that haven't been replaced by comparable opportunities in the growing service sector. This has constrained upward mobility for people without a college degree and aligns with the argument made by Ann Case and Angus Deaton that declining economic opportunity has prompted so-called deaths of despair. There's several direct and indirect pathways through which this process could occur. First, prior studies have shown how the experience of job displacement can increase substance use and alcohol consumption for laid-off workers and for their family members. But second, indirectly, the decline of local economies might have spillover mental health effects that extend to the broader community, and this might promote drug uptake. So I asked two questions. The first is, what's the association between manufacturing decline and drug overdose mortality? And second, how much of the increase in drug deaths that we've observed over this 2-decade period, how much of these can be accounted for by manufacturing decline? So what I've done is, to answer these questions, is I created an annual data set that combines, at the state level, it combines restricted use data on drug deaths with economic activity data and other sources of data as well. And I adopt the theoretical approach of conceptualizing states as laboratories to study population welfare, since state-level contexts and policies are important determinants of population health outcomes. Moreover, states have adopted very different regulatory and legislative approaches towards tackling the rising toll of opioid deaths in particular. So through two-way fixed effects models, I adjust for the implementation of public health regulations, including prescription drug monitoring programs and naloxone access laws. I also conduct a number of sensitivity tests that further account for variation in the local supply of opioids, including state-level trends in the supply of legally dispensed opioid prescriptions. I'm going to present my results as the share of total drug deaths that have occurred, which can be predicted by manufacturing decline. So here in this graph right now, we see the total number of drug deaths for both women and men, which make up that combined 700,000 drug deaths. So based on my estimated models, what we see is that this economic restructuring does indeed help explain some of the spatial spread of drug overdose mortality. The findings here suggest that manufacturing decline predicts about 34,000 of all overdose deaths for women and 93,000 of all overdose deaths for men between this 1999 to 2017 time period. This is equivalent to about 13% of all drug deaths for women and about 22% of all drug deaths for men. Now, if we want to measure the drug epidemic through other measures, we could also look at whether manufacturing decline predicts opioid-related healthcare utilization. And what I find when switching out the dependent measure here is that the loss of manufacturing jobs can account for 22% of the increase in visits to emergency departments and 12.1% of the increase in short-term inpatient hospital stays that are opioid related. Now, you might be concerned that there are other state-level processes that co-vary with the rise of drug overdose deaths. So you can stop by my poster afterwards and we can discuss how these results persist in multiple sensitivity and robustness models that adjust for more state-level trends as well as alternative measures of manufacturing decline and drug mortality. But overall, the findings here contribute insight into how ecological risk environments shape population health outcomes. Through this research, we might better understand how upstream social and economic factors have influenced the wide-scale take-up of drugs in recent decades. And this could lead to additional avenues of clinical, public health, and public policy interventions, which will perhaps help address the most pressing public health crisis of our time. Thank you.
All right. Hi, everybody. I'm Joseph Clark. On September 1st of this year, I took over as the T32 postdoc for CDHA. So it's been a really excellent day of learning more about the history of CDHA and the sister centers. And it's been a really fun 3 months so far. It's been a fantastically good experience for me as a researcher. I think we've heard a lot today about the excellent research that the CDHA does, but not so much about how fantastically warm and welcoming this place is. I've had the opportunity to visit a number of elite departments in my short career so far, and this place truly seems special. I'd like to thank Jason, Marcy, and Mikhail for being so generous with their time and advice throughout the semester. And the paper I'll be presenting today is research with Jason, with assistance with Q and his lab, and it is about religious contexts or social contexts more theoretically broadly, and genetic influences on drinking and health behaviors. So first, what do we know? We know that the heritability of health behaviors can be influenced by uniquely social factors. So the social environment shapes your shapes the effectiveness or power of your genetic predispositions towards behaviors such as drinking. So heritability of disinhibition and problem alcohol behaviors appear to be moderated by individual level religion. There are two primary papers that show this. Boomsma in 1999 looked at the effect of individual religion on the heritability of disinhibition amongst adolescents, and Button et al. Also used a twin study to look at alcoholism, I think, and binge drinking. So what do we not know? So individuals don't practice religion on an island, right? Even though this is something that is very personal, it's something that is also socially influenced. So religious context matters for a ton of important individual and community level outcomes, such as mortality, morbidity, health, social mobility, crime, pretty much anything you throw at the board, religion appears to have some sort of influence over. So a natural question that follows from this line of research is, do religious contexts moderate the heritability of health behaviors, such as drinking? This little graph here is a sociogram back from 1952 of children within a classroom. And I'd like to think of kind of individuals as nested within these larger social contexts as we look at this research here. So our data and measures, we pull data from UK Biobank to generate, using GWAS to generate polygenic scores that we then kind of imported into the AdHealth data that give us our PGS for drinks per week and PGS for binge drinking. We have religion variables at the level of maternal religiosity, which kind of gives us a family level religious context, and then peer maternal religiosity, which gives us kind of a larger social context that adolescents are nested within. And then for drinking behaviors, we have binge drinking, ever having consumed alcohol, and average number of drinks per week. And just a real small snapshot of our findings. These are school fixed effects looking at adolescent binge drinking. And so we can see that we have a our PGS for alcohol significantly predicts binge drinking, and maternal religiosity appears to be significantly predictive and quite powerfully predictive, preventative of binge drinking. And we also have a measure of peer maternal religiosity that has a smaller influence on drinking behaviors. And in fact, it's not significant in the broader sample, but when that sample is stratified by high and low polygenic risk scores for drinking, it becomes significant for those who have the highest predisposition towards drinking. So a quick takeaway from this is that religion seems to matter, religious contexts seem to matter quite powerfully, or more powerfully for those who are at greatest risk for drinking, problem drinking behaviors. And so not only do proximate religious contexts, so that those at the family level matter for controlling drinking behaviors, but also these more distal contexts, so these broader contexts and communities that individuals are nested within seem to play a role. So that's just been kind of a quick snapshot of this research, and I look forward to talking with some of you over at the poster.
I'm Jessica Polos. I'm a PhD candidate in sociology, and I'll be presenting on care life expectancy, gender, and unpaid work in the context of population aging. This is joint work with Ariane Ophir, also a PhD candidate in Soc. So as a bit of background, the context we're looking at is that of population aging, wherein a greater proportion of the population is placing demands on health systems, pension systems, and also has a greater demand for care, while there's a smaller proportion of the population that's able to meet those demands. And typically, the conversation in population aging has centered around economic and financial concerns, for instance, looking at the duration of working life, but has largely overlooked caregiving life. In addition, measures of caregiving have focused on potential to give care or on one specific life stage, for instance, child care or grandchild care. And from that literature, we have learned that caregiving is gendered across each stage of the life course. But we seek to introduce a metric of caregiving that's cumulative across the life course, and we bring caregiving into the demographic discourse in this way. So our research questions are, what's the duration of caregiving life? How many years can women and men expect to live as caregivers? And in this case, we're looking at family members, giving care to just family members. How does care life expectancy change by varying intensities of caregiving? And what are the cross-national patterns in care life expectancy? We use data from the European Social Survey. It's nationally representative of the population 15 and over. We look only at round 2, as this round is the only one that's gathered data on caregiving. And it was collected in 2004 and 5. We used 23 European countries with sample sizes ranging from 1,600 to 3,000. And we combine this with life table data from Eurostat. Our measures of care, again, we look at just unpaid care to family members. And we break this into 3 different levels of care. High-level caregiving is that provided to someone in the household or provided daily or several times a week to someone outside of the household. So the care outside of the household might be things like grandchild care or giving care to elder members of your family, helping them shopping, etc. Medium-level caregiving is care provided outside the household once a week or several times a month. And low-level is care provided outside once a month or less. So what we do is we collapse those measures of care, which are measured at the individual level. We dichotomize them and then use them to generate age, country, and sex-specific proportions of care given at those varying intensities. And we combine that with the life table data to determine the expected life as a caregiver. So in all, we generate the number of years the average person at a given age is expected to spend in a caregiving role. So here are some of our results. We have the map of our countries in Europe, and the one on the left is women, the one on the right is men, and what you'll first notice is that the range of total care life expectancy differs by sex. Women are expected to spend between 27 and 49 years as caregivers, whereas men are expected to spend between 17 and 50 years. Additionally, you'll notice that Northern Europe tends to spend a longer amount of time giving care compared to Southern Europe, and that continental Central Europe has more variation and is in between. Additionally, this is care life expectancy at age 15 by intensity and country, and it came out better than I thought on this big screen. So the top of the bar is life expectancy, and then the graph is broken down by the intensities of care. So the black bar is the daily or intense measure of care, and the lighter gray, it grades up. On the left is women, on the right is men. So you'll first notice the gender disparity in care. Women tend to give more care, even at lower levels, but you'll definitely notice this at the higher daily care intensity that women across the board tend to give more years of care. And then on the left of the graphs is Scandinavia, and on the right is Southern Europe. So again, there you will note differences in types of care. So Scandinavia tends to be more gender egalitarian, and you see that men and women are more similar in the amount of care they provide, whereas Southern Europe is less gender egalitarian and has a larger gender disparity. In addition, Scandinavian countries tend to provide a greater number of years in care overall, and a smaller proportion of that is intense care compared to Southern Europe. We do have some limitations. We can't measure transitions between states, so who's coming in and out of different caregiving roles. The data is a bit older. It's from 2004 and 5. Since then, there's been an economic crisis, changes to retirement ages, et cetera. We'd love to have data over time, but we don't have that. And this data doesn't have components, so we can't break down care by whether it's given to children, grandchildren, et cetera. So overall, adults, and to a greater extent women, spend a significant proportion of their lives as unpaid caregivers. Care life expectancy is a summary measure of various caregiving activities across the life course, and we can use it to draw attention to gender disparities and cross-national variation. And these measures really serve as a benchmark against which we hope future demographic and policy changes in unpaid care work can be tracked. And finally, countries seem to cluster in care life expectancy by policy regime and social context, more so than by demographic regime, but we know that these processes are endogenous. Thank you.
My name is Leafia Yi. I'm a doctoral student here, and this is actually my 4th year here at UW as a doctoral student and as an affiliate at the center. And I'm finally at that point where I have like a couple of my own research projects going on, which is very exciting. But also I was joking with a friend the other day that I feel like I'm in the first stage of a demographic transition where my papers have very high fertility, but also very high mortality. And so honestly, this is actually one of these ideas that's only been recently born, so I definitely am looking forward to hearing your comments and advice. This paper is titled Understanding Age Patterns in Immigrants' Initial Health Advantage. Immigrants' initial health advantage is this phenomenon that upon arrival, immigrants are healthier than their native-born counterparts. This has been documented on a wide variety of outcomes and across many societies, including the US. There are many explanations for why immigrants may be healthier upon arrival, but one of the main explanations has been migration selection, namely that moving to a different country is a physically taxing process and only those with the most robust health profiles will be able to make the move. This has also been very much built on this ideal type of an immigrant who come to the US looking for a job and for which they definitely need relatively good health to support them for a relatively successful economic life in the US. At the same time, about 2.5 million immigrants in the US actually arrived after age 60, so after their prime working years. This number has actually more than doubled since 1990. And so these immigrants potentially have different migration processes and different selection mechanisms. And so it's very possible that they may have very different initial health profiles compared with their earlier arriving counterparts. Most likely, they may have a weaker health advantage or even a health disadvantage compared with the US-born because they mostly come for family reunion and not for work, for which they don't really need to have great health. I propose, however, that it's also possible that later arriving immigrants may have a stronger health advantage because when people are older and moving, they're more concerned about their potential health problems. And if you're arriving in the US after your prime working years, most likely you're also not going to be eligible for stuff like free Medicare in the US. And so maybe people would not move to the US unless they're relatively healthy. So these are the questions that I ask in this paper. Compare with a US-born, to what degree do late arriving new immigrants have a health advantage? Are they more or less advantaged compared with immigrants arriving earlier in life? And can we explain if there are any age patterns in the initial health advantage with migration intention and with health insurance status? My data are from the National Health Interview Surveys. I measure health as a binary indicator of self-reporting health as fair or poor. This measure would allow me to draw easier comparisons of people across different ages. I define new immigrants as those who have been in the US for less than 5 years, assuming that their health hasn't changed that much since they first moved here. And here are some results. On the y-axis here is the predicted probability of having fair or poor health. And so compared with the US-born, who are the blue dots, new immigrants, who are the gold dots, we can see at earlier ages do have an obvious health advantage initially. This pattern is not observed, although for immigrants who come to the US when they're 60 to 69 and after they're 70 years old. And so this seems to go along with the first mechanism that I suggested, that late arrivals maybe don't have as great of health because they didn't come to the US to work. Following that, we should observe that those arriving earlier in life who are also not here for work should also not have an initial health advantage, and those arriving later in life for work should still have somewhat an initial health advantage. However, I could just compare immigrants who are working versus not working, but I'm concerned about reverse causality, where you might just not be working because you're not healthy in the first place. Instead, I decided to compare those who report being unemployed versus those who are not in the labor force, because neither of these people are working, but they may have different intentions. Those who are just came to the US and report being unemployed are intentionally in the US for work, versus those who report being not in the labor force are not here for work. And so I did find partial support for this hypothesis. I say partial support because for the people who are unemployed, which is the the green dots here, we still see somewhat sizable of a health advantage at older ages, between 50 and 60 years old. I didn't have enough people that reported being unemployed at 70 to 80 when they first got here, which sort of makes sense. Compare with the US-born, though, those who are not in the labor force, the red dots, we can still somewhat see a health advantage at the earlier ages. So that doesn't really go along with the hypothesis I have. So I would call that a partial support. The second mechanism was that older arrivals are not eligible for Medicare, so maybe they wouldn't migrate unless they're healthy. To test this, I think older arrivals who are covered by insurance, they should be as selected on health they should not be as selected on health as those who are not covered by insurance. And insurance status should matter less to initial health at younger ages, because younger arrivals don't have the same level of health concerns as their older counterparts. And I did find support for this hypothesis, where, as we can see, at younger ages, it seemed that health insurance status didn't really matter for your initial health. So regardless of whether or not you're going to be covered by health insurance, initially when you're in the US, you're relatively healthy. When we look at older arrivals, we see that only those who are not covered by insurance have an initial health advantage. And those who are covered by insurance actually appear to have a disadvantage in later life, although the evidence are marginal. And so, in summary, I did find an initial health advantage among those arriving before 60 years old. I didn't find sign of an advantage among older arrivals. Part of the age patterns seem to be able to be explained by age differences in migration intention. I still found an initial health advantage among old age immigrants who are uninsured. And I think this implies that the wealthier immigrants who are sure that they're going to be able to purchase insurance when they come here, they don't need to be healthy. but the less wealthy immigrants who know that they won't have access to free health care, they are selected on health. Thank you.